Thank you for coming. We're just waiting a few more minutes before we get started. Hi, Shahid. Would you mind unmuting yourself just to check that everything's working?
Can you hear me?
Yeah, can we just wait a couple more minutes
Yep.
people to gather? And
Yep.
in the meantime, I just want to remind everyone that this is actually the second of a two-part series.
Yep.
If you look at the description, you should be able to find a link to Shahid's event yesterday and give it a listen. There's a recording available. And in this event, you can ask questions in two ways. You can either raise your hand at the end of this event, ask a question, or you can use slido.com to submit a written question. So to submit a written question, please go to the website slido.com and use the code R0903. That's R0903 on slido.com. And if you are a bit confused about the code or anything, the instructions for how to use Slido are in the description of this event. I'd also invite you to please follow researcher highlights for events like this, which don't necessarily fit in any one category on our website. There's some really exciting things going on all the time, so please make sure you follow. And yeah, I think that we are about ready to get started. What do you think, Shahid?
Yeah, just give me 2 seconds. I'm just writing a quick note, and I'll be with you just now.
Yeah, just to give people a little more information to be able to view the slides in the presentation that you can see on top. Just click the arrows and it will take you forward and backwards, so you can see old slides as well as slides that are coming up. Shahid will give us some cues onto which slide he's on. And again, please make sure to submit any questions you have on slido.com during the event. Or you can just raise your hand at the end of this event to ask a question directly. How are you doing, Shahid?
Okay. Yep, that's fine. Okay. So I'm ready to start then. So I'll crack on then. Is that okay? Yeah.
Yeah,
Okay.
I think you can get going.
Okay. Thank you very much. So thank you once again for the researcher app team allowing this sort of collaborative effort in relating to World Kidney Day, or in support of World Kidney Day, and a collaborative effort between the researcher app team and the renal patient support group, or the RPSG. And today I'm going to talk a little bit that follows on from the presentation I gave yesterday on the 8th of March, which related to some aspects around something referring to nephrotoxic nephritis. Today I'm going to talk a bit more about the science behind nephrotoxicity and the importance of reduced immunosuppression in pediatric transplant patients. But suffice to say, the presentation I'm giving today does have a little bit of a remit around the adult nephrology population, those going through kidney abnormalities in between pediatric between the pediatric population and the adult population. So this is an overview on the science behind nephrotoxicity. So this is slide 1. I'm now going on to slide 2, and I'm going to give you a bit of introduction. In relating to this topic as a general theme, is that biomedical scientists, immunologists, and clinical scientists tend to collaborate best when there is a consensus in investigation of renal transplantation. Looking at renal transplantation amongst pediatric patients, but also, of course, those in the adult population in the adult population, and those who require sort of transplantation following diagnosis of going through renal insufficiency for whatever the reason might be. Now, such collaborations are also envisaged best when there is a determination in the development of ensuring safe efficacy of immunosuppression therapy with reduced side effects, including nephrotoxicity being one of the main things, and especially more so post-transplantation. Now, ironically, nephrotoxicity can occur obviously as a result, for example, where individuals might be diagnosed with something that's referred to as acute kidney injury, or AKI, which might lead them into having which might lead them into having a renal insufficiency. But as in line with this, what it also means is that even when they're on a form of, for example, kidney replacement therapy or renal replacement therapy, in that time, nephrotoxicity might be less likely to occur to some extent, but that's not to say that it can't happen at all. It can still happen. Now, post transplantation is even more of a risk, because many patients, especially in the pediatric population, as well as those in the adult population, and going through this particular area, in particular issues relating to where nephrotoxicity can occur, the physiology, especially around the kidneys, can have susceptibility and vulnerability, and especially where patients in both populations, generally speaking, are would have to take or be prescribed certain medications that can also prompt issues around the kidney physiology. Now, to identify best possible transplantation and match for pediatric sufferers, and allowing prolonged renal function, or serology laboratories focus on a few main things, and that is cross-matching, which is also cross-matching, and tissue typing, which is generally the consensus and consensus that relates to cross-matching and tissue typing. Tie into where clinical scientists have a remit to support clinical practice to ensure patients have the appropriate transplantation organ, when it comes to transplantation and organ transplantation. Ensuring that they have the best possible cross match alongside with their blood group, and also different paneling techniques are also organized in part of the serological workup of those patients, both in pediatrics and in adults who might require transplantation. Now, the importance investigation for possible match include lymphocytotoxic tests and mixed lymphocytotoxic culture tests, and both are forms of tissue typing. Now, a clone match can't really be established or identified unless a pediatric recipient is a twin, or what's referred to as a complete human leukocyte antigen compatibility, and referred to as a full house cross match. So HLA, the human leukocyte antigen, along with the aligned with the MHC, which is the major histocompatibility complex. But generally speaking, when there's when serologically speaking, the tests and investigations are a kind of um, best matched. Basically, clinical scientists would refer this to as a full house, but a full house, generally speaking, in a full house in its entirety would not occur unless unless it's a twin donating an organ from to another twin or a sibling in this regard. However, close to this is those who are live cadaveric, live donors, and also potentially cadaveric, where apart from blood, there's an age matching aspect that comes into this, and then also in relating to again the HLA and MHC, where basically the immunological components are much closer. Thus, actually, when patients are required to have post-transplant anti-rejection therapy, for example, there should be less probability of having nephrotoxic side effects. So, in this regard, also, where twin donation or twin donation is evident or can be achieved. This relates to an isograft. Isograft is the terminology allowing survival of kidney transplants 10 to 20 years post-transplant, and quite well. That's suffice to say that there is a prognosis around isografts, around cadaveric and live donors that are not that don't fall in the category of isografts, that can also have a good prognosis. Okay, so that's some general introduction. Now I'm going to go into slide 3 now. So I mentioned a little bit about donors from where transplantation is concerned in relating to for example isografts, and a little bit about live and cadaveric. But a little bit more emphasis here is that donors such as live from those who are living relatives, and also cadaveric recipients where they receive a transplant from a donor who has been pronounced as someone who's brainstem dead, have also been retrospectively appropriate, and of course basically as I'm sure to some extent listeners may know, that there has been literature published in various by various known authors relating to the fact that there has been in the past issues around the supply and demand aspect around organ donation and transplantation. And basically what this means is that the patients have to wait longer in some regard, and basically this is because the aspects that are related to the immunological parameters that are also linked with the major histocompatibility complex and the human leukocyte antigen characteristics are not going to be, and are less likely to be, or there's less probability for them to be identical, except again in live donors where there is a greater match complex, and again that relates to isografts, but those where the immunological components are less likely to cause or elicit a response that an attack a foreign organ. And we must know, we must understand that when a transplant is enters into the donor's physiological as part of their physiology, it will always be foreign. So that's something we must appreciate, and thus a decent match only occurs really because the scientific aspects that relate to the serological testing investigations and the constituencies around that are similar, not identical, but they are similar. And then basically cadaveric transplants show greatest risk of rejection, but can be decent cross matches if carefully selected for post transplantation. Now, apart from clinical scientists and biomedical scientists getting involved to actually do part of the testing investigation and the laboratory medical aspects that are needed and required, there are also clinicians who are going to be who are going to want to know how best to ensure patients can get the best out of their transplant prognosis. A sibling to sibling donor where HLA complement is similar should have seven can have 7 or more years prognosis. Now, generally in literature, on a generic basis, those who have live donors in literature retrospectively has highlighted that from live donors, the prognosis can be something in the region from 10 to 15 years or 15 years plus, rough as an estimate. And with cadaveric, it's between 8 and 10 years. And generally because when transplanted from a cadaveric donor to someone who's live, it's different because someone is being pronounced dead, or brainstem dead when being transplanted, or when an organ is being donated, versus a person who is his life at the time. So basically, the prognosis has some basis around that. Now, apart from this, in relating to the MHC and LHA characteristics between pediatric patients, the chance of a prolonged functioning kidney transplant survival thus reduces or is reduced based on the fact that the cross match and also aspects that can additionally be affected is where, for example, a pediatric patient could have their transplant from someone who's older, and that might not necessarily be ideal, although it's not a terrible disaster as long as all the other serological components are identical, are similar. Now, in relating further, rejection of transplants occurs mainly through what is known as cytotoxic T cell effects, and immunosuppression and the probable nephrotoxic side effects basically then can cause or are probable to cause challenges, because the T cells in detection of certain antigens and destination of renal and destruction of renal grafts or renal transplants, anti-helper cells aid in appropriate recognition of complexes. And basically what happens is that in a worst case scenario, for example, if for example let's say, for example, the immunological components are similar, but let's say from an HLA perspective, basically where on a panel test, where clinical scientists and some biomedical scientists might be involved, basically on a serological test, on a cross match test, basically out of the what's referred to as the lymphocytotoxic T cell test and a panel test, basically out of that where on donors on donors and where transplants are being matched, there's a six panel cross match test that has been implemented, and retrospectively, if there is even say, let's for example, three mismatches, and the other three, for example, match very well, then what can happen is that the patient, if transplanted, at that point, basically they could be placed on higher doses of anti-rejection treatment or immunosuppression, and that prompts more an illicit response in relating to not just nephrotoxic side effects from the immunosuppression, but also problems where basically in a kind of a roundabout way, what happens then is that the immune system and these certain cell types, the T cells, CD8 primarily, cause a destruction of the transplant. The immune system gets elicited a response to the extent that CD8 T helper cells, CD8 cytotoxic T cells cause a response to then prompt the transplant to reject, and that's obviously going to be devastating for patients, in patients as well as people around them. And now, thus, ultimately, there will always be some form of risk or of having a form of transplant rejection. So now I'm going to move on to slide 4. So a little bit about donor and age matching in renal transplantation as well, because this is quite important, and I know I've touched on it on the previous slides, but just here to say basically that three main points here. Unlike other transplants, the kidney, where the kidney is concerned, has ABO implied sugar antigens articulated on the endothelial cells of the blood vessels. So of the blood vessels that are around the kidneys, there are these what's referred to as sort of sugar antigens around the endothelial cells. Now, thus, if the donor recipient has different, apart from the blood group complex from the recipient, so if the donor recipient and the one who's donating versus the one who is the recipient, if there is difference in those characteristics, again, the antibodies will result in a what's known as a type 2 hypersensitivity reaction in the renal graft. And basically, worst case scenario, as I mentioned in the previous slides briefly, where the immune system can elicit a response, and in particular CD8 T cells can are propagated. What can happen in a worst case scenario is that on the operating theater table, where a patient is being undergoing surgery, as soon as a kidney is put into the body of a patient, what happens is that surgeons and those around the clinical team will know definitely that straight away, basically by the reaction of the physiological by physiology, whether the transplant's going to be successful or not. Because what happens where type 2 hypersensitivity reaction occurs, and especially around renal transplantation, is basically the actual organ turns into a different color from what is naturally what the natural color would be. So, for example, where kidney transplantation is concerned, it can go from like the warm blood type color, which is part of our physiology, can turn into for example a bluish type color. So that's this part of a type 2 hypersensitivity, but also something that's referred to as a cell mediated response. And so thus what happens, there's an elimination of the transplant through these cytotoxic T cells, and CD8 again according to in line with the major histocompatibility complex. Now this is important because basically where immunology is concerned, like for example when we're fighting off a general infection, no one can really appreciate like the physical component of the immune system. Like we don't know where our immune where physically where retrospectively where where the immune system within our physiological and as part of our physiological makeup, where that actually exists. So or if it exists. So retrospectively, literature has said, for example, that you know where people say I have a gut reaction, for example. Now the gut does have a lot of a lot a kind of an important role, where important focus around the immune system. But I won't delve into this around this because it kind of goes off topic a little bit. But just to also say now, as the second point here, the T helper cells, which are referred to as a CD4 in the as part of the major histocompatibility complex in that regard, aid really in the acknowledgement of transplants, thus binds to explicit areas of the MHC complex. And graft recipients or grafted recipients might also have some HLA through rejection of preceding graft. Thus, so what this means is that, so say for example, paediatrics have had a successful transplant up until a point, but let's say also retrospectively or at that time, the transplant according to the MHC and HLA was not very good, or the cross match test. The panel test shows that there probably would be that it would be a successful transplant, and it could do well. However, what can happen is that the immune system is always going to be sort of in one way in a dormant state, but also in a state where it's going to can be ready to attack. Now, basically, when the immune system when a transplant is concerned, if it's not very good, then there's a higher probability that the immune system will elicit a response much quicker. But the time and the duration would not actually be known because again, immunosuppression or anti-rejection treatment has a lot to do with keeping the immune system kind of in a tolerated state. And so basically, what I'm getting at here, listeners, is that basically that there is this sort of especially applies for pediatric patients, because if they're young and they've had a transplant, then it is probable that they may require another one later, and this might be because apart from the immune system, there is the anti-rejection medication that they are on or will be prescribed also cause problems, and this also relates to the nephrotoxic side effects, and also again the worst case scenario is that, again, if the cross match isn't very good, but also where clinicians say, for example, that if dosed with appropriate immunosuppression, that can actually allow the transplant to have longevity. And so, for example, in pediatrics, for example, in some contexts, where transplants, for example, if they're not cross-matched at the best, and a worst case scenario, for example, and I say a worst case scenario because basically there will be children or young people who would require a transplant because, for example, other forms of treatment or renal replacement therapy, for example, are not going to work very well, or may not work very well because of how they may have been diagnosed, and the workup around the clinical aspects that have devastated parts of their physiology over time. So in a worst case scenario, they may be on higher doses of immunosuppression, even with a potentially not very good transplant. So basically, over time, what will happen is the transplant will reject, but the patient will then, in that time it rejects, they basically may have a chance whereby, if they've managed to grow up or develop quite well, and I mean this from a physiological perspective, then basically, if they had to go back on a form of renal replacement therapy, then that can, in some way, or albeit it might sound a bit off, it might help them it might help, and then basically, when a transplant becomes available again, it may well be that the memory cells around the immune system actually forget that that the previous transplant had caused antigens or antibodies as well, to actually propagate a transplant rejection once they have another transplant, which could be cross-matched better. Now, as with other health complexities that have a significant immunopathogenic component, a variety of renal illnesses or kidney illnesses have associations with the MHC again. And the first of these to be illustrated was actually something that was associated with and among something as known as the DR2, DR2, and DR2 is actually what's referred as a loci, or a kind of a segment, a part of the H, a link to the HLA and part of MHC, and in this context, it's an association among DR2 and anti-glomerular basement membrane disease. Now, subsequently, several different MHC alleles have also been coupled with a variety of other renal diseases. Now, this is important because again, when it comes to donor and age matching in renal transplantation, basically matching, for example, retrospectively, and I would encourage listeners to sort of check out the literature at their own time. Retrospectively, in literature, it says that in the field of nephrology or clinical clinical practice or laboratory practice around tissue typing and serology, there has been retrospectively a basis where, for example, that age matching as a part age matching, cross matching, the tissue typing and the ABO blood grouping, 3 or 4 components had to be absolutely correct or right in order for a transplant to go ahead. But as advances have gone on, basically age matching, ironically and funnily enough, have actually not been as higher as high or as high in relating to where in relating to the immunological aspects around cross matching and tissue typing are more important. So thus, because when looking at nephrotoxicity and nephrotoxic side effects, age matching or age is not actually much of an issue as much as it used to be. And now, and this is because the serological aspects around cross matching and tissue typing had early phases where even clinical scientists and clinicians, of course, were still kind of sort of experimenting and trialing different ways to ensure that in the field of nephrology, generally speaking, have the best that where recipients can have the best tissue type, and that will be, albeit whether from whether having a transplant from a live donor or from a cadaveric. So I want to share that understanding, because it's important that basically age matching is no longer really much of a sort of a consensus. Although when in pediatrics it's the same, but albeit on this from this perspective, clinicians in pediatric nephrology versus those in adult nephrology, for example, would prefer basically age matched donors. And I'm sure anyone who's listening on this in the audience will know that is important. So I'm now going to move on to slide 5. And some just a few more points here around donor age matching and matching in renal transplantation. So the techniques from MHC typing are evolving or advancing, and they have been over at least the last 15 years, I would say, quite easily, from serological testing and investigations to molecular based methods. Now everyone knows, for example, we've had this whole pandemic over the past 2 or 3 years, since 2019, early 2019, and in laboratory medicine, for example, molecular based methods have in some respect have always stand the test of time, because generally speaking, the results that can be highlighted through molecular based methods of testing in relating to this area or specialty, basically provide quicker understanding for clinicians to implement the appropriate action when providing the go-ahead, for example, to have a transplant. Now, I say COVID. I said the pandemic. I mentioned this briefly because, as everyone will know, with COVID-19, where people have had to get, for example, PCR testing. PCR testing, as everyone knows as well, is a form of molecular based method, and generally speaking, we know that with molecular testing, again, whether it's through virus testing or virology or in general serology, and again in relating to in relating to the pandemic. Basically, it gives a quick turnaround time. So I'm just giving that as a kind of a throw out example, because basically the turnaround time for where patients would require a transplant. The idea is to with transplantation, molecular based methods also reduce the time in how long individuals would have to stay on the waiting list as well. So it's important to have that understanding. And then in addition, these examinations are frequently can be costly, and do not always have place in everyday clinical practice. Whereas, for example, if you think about, for example, the full blood count, if a full blood count, or doing a urinalysis, for example, generally speaking, both of the those two modalities where test and investigations will be required. There are various methods that they can be done, but molecular biology from a molecular based methods, it's not going to be adequate or feasible or even viable to do those kinds of those tests on a daily basis, no matter how accurate or how sensitive the tests are, because basically the costs in relating to in laboratory practice is just gonna skyrocket, because basically it's going to cause there'll be problems if basically the tests and investigations are requested on a molecular based method frequently, for example, at least from those two kinds of tests. Now, in complement to the MHC, several other genetic indicators that may be linked with a variety of renal diseases are also being explored, but these are also currently mainly around a research intrigue. So these can include immunoglobulin receptor polymorphisms and variants of alpha-1 antitrypsin in systemic vasculitis, and associations between the various allotypes of the immunoglobulin molecules and anti-glomerular basement membrane disease. Now, the techniques and the investigations that I'm sort of highlighting here, or at least these sort of markers that can be used to indicate whether apart from a transplant going ahead or not, anti-glomerular basement membrane disease, or GBM, basically in general nephrology, or and even in areas of clinical science, generally anti-glomerular basement membrane is generally a general kind of a form of a kidney disease, basically, that can be used as an experimental basis to test and understand basically all kinds of immunological markers or biomarkers, because retrospectively the literature around glomerular basement membrane disease is actually quite vast, alongside other particular diseases. Now, research informs that kidneys from older donors into young recipients should technically be avoided, and these kidneys should be given to age-matched recipients. So I've mentioned that and given that example from from a pediatrics or young people requiring transplantation. Age match is something that is retrospectively was not always interplayed, but as advances have carried on, basically clinicians in pediatric nephrology, as again will want to make sure that there's an age match aspect as well. So I'm now just going to move on to slide 6. A little bit more into the I guess the nitty gritty around nephrotoxicity and immunosuppression, and in keeping, of course, with the science behind nephrotoxicity. So transplant pharmacotherapy has advances as new agents are investigated and approved for use, and generally there can be immunosuppression or anti-rejection treatment that go through various clinical trials or clinical trial phases. Plus, there will be a process where towards the end of a clinical trial, based on a particular anti-rejection or immunosuppression therapy, there is a period where a duration where for example, the FDA, for example, the Food and Drugs Administration organization will have a sort of a premise where they're involved in ensuring that can go out to go out onto the main market, onto the as main forms of pharmacotherapy. Now, solid organ transplant recipients depend on multiple immunosuppressive drugs, and I say that quite loosely to some extent because, again, as if there's kind of so I'll give the example again where there's a full house transplant, where basically you have a recipient who matches well across various immunological and tissue type kind of components. Then basically there is less probability to some extent that they will be on multiple immunosuppressive therapies. They could be on minimal dose immunosuppression or anti-rejection treatment, and this is basically because as I mentioned in one of the earlier slides, there's the full house, which is basically the full house is related to isographs. Now, which so isographs are identical, where people a sibling or a sibling matches identical to another sibling, and it's an isograph based on the fact that they're twin, that the genetics are pretty much identical. Now, in other areas of serology, that doesn't really happen, but as I mentioned, the serology can be matched quite well, so that actually, again, the immunosuppression or anti-rejection treatment that patients might be on can also be minimal, or might be on where patients might be on limited amounts or low dose. Now, in relating to this, these patients often can require other therapeutic agents to treat underlying illnesses, kind of to in a way to offset the probability that for example an episode of rejection will occur. Now, anti-rejection therapy on its own should do that, technically speaking and scientifically speaking, but at the same time, those I'm sure who are listening in on this can will appreciate, or can and would and can and should kind of appreciate the fact that basically once someone is transplanted, there can be a higher probability of having where patients or individuals are, irrespective of being in a pediatric patient population or adult population, they can have higher probability of having comorbidities. Now, this then prompts the use of other medication or other regimens to offset the probability of issues occurring around a transplanted organ. So I want to highlight this because this is important where nephrotoxicity is concerned. So the more for example, polypharmacy, or the more drugs or medication that individuals are on, then that can elicit nephrotoxic side effects. And then what will then happen is that it won't take much, or almost anything for actually the immune system to launch a CD8 cytotoxic T cell attack, and then you get certain other biomarkers. Other immunological markers. For example, one of the ones that is known quite well, for example, and I haven't mentioned it in this presentation so much, but one that does come to mind is something that's referred to as the CXCR3 chemokine receptor, and sort of the cytokines that are aligned with that. And basically, there's a movement, a migration of CD8 T cells, because CXCR3 also CXCR3 chemokine receptors are actually part of that migrate are part of the response, and cause a migration of the CD8 cytotoxic T cells much faster, or quicker. And so this is important, and that's why generally a low dose immunosuppression therapy actually should prevent that from happening. So wherever a new medication is administered to a transplant recipient, the potential exists for increasing or decreasing tissue concentration of immunosuppression agents. And I mentioned the word tissue concentration of immunosuppressive agents or immunosuppression. And what this is basically where all immunosuppression or immunosuppressive agents or immunosuppression have to be monitored according to a therapeutic drug monitoring, or TDM. And basically all drugs or medications, whatever individuals are on, have to follow or be within apart from the TDM or therapeutic, where they are therapeutically monitored, they have to fall under a curve. And this curve is referred to in pharmacology or pharmacotherapy language, is basically the area under the curve. And that area under the curve is basically where nephrologists in pediatric land or in adult nephrology land generally will want to make sure that there's safe dosing, and area under the curve can prompt and encourage clinicians to sort of ensure safe practice around that. Thus, so this can lead to serious complications such as over immunosuppression and infection under immunosuppression, and an acute rejection, or additive toxicities, including nephrotoxicity. If, for example, the immunosuppressive agents or immunosuppressive agent or immunosuppression is not monitored very well. And so I wanted to make sure that that listeners have that understanding. And now on to slide 7. So during the past decade, or a little bit longer actually, listeners, several new potent immunosuppressive agents with different modes of action and different side effect profiles have become available. And I mentioned how, for example, in the UK. So in the UK, there's an organization known as the MHRA, which is the Medicines Health and Regulation Authority. I believe it is. And in the US, on the United States, I mentioned there's the FDA, the Food and Drugs Administration, and basically they're a likeness. They have the same sort of role, same sort of function, whether in the US or UK. And basically, what happens is that what happens here is that the different modes of action and different side effect profiles are kind of known in advance, and so in some regard have to be declared with the MHRA and the FDA before any pharmacotherapy goes on market. If there's too many effects or side effects, then obviously it can't any particular immunosuppression or immunosuppressive agent cannot come out on cannot be kind of put onto market in this regard. So nowadays, immunosuppression after or post renal transplantation is no longer one single regimen, no single regimen applicable to all patients. So basically, it's kind of a kind of a touch and go situation, because what this means is that basically individuals who have transplanted might be tested on different immunosuppression to ensure to ensure that the immune system tolerates, and this is tolerate is one of the main words in immunology language, basically where the immune system against physiological parameters, if it tolerates for example a transplant or something that's foreign, then basically that means that the treatment that pediatrics might have it would be viable. So in the selection of the optimal immunosuppressive protocol, individual drug-related toxicity, recipient-related risk factors, as well as donor organ characteristics, all have to be considered. So again, immunosuppressive agents or immunosuppression generally has to be lined up alongside when individuals have are having the appropriate. There's again, as I mentioned, serological testing and investigations as part of the process in the requirement of having a transplant. Now, and again, this all relates to how really there's more now than ever an importance where nephrologists, again in pediatrics and in adults, do all they can to ensure that individuals are on a reduced immunosuppressive or immunosuppression treatment sort of protocol, so that basically especially in pediatrics, that they can actually live sort of longer and longer lives with less probability of having to go through different comorbidities as well. And it's kind of a big ask, but it is important to make that known, because if you think about it, if a young person or pediatric is transplanted versus someone who is older, basically they have to deal with the effects, whether there's immunosuppression, nephrotoxic side effects from that immunosuppression versus other treatment procedures, a lot longer than those who might be diagnosed with a form of kidney or renal disease sort of later on, middle age or later on in life. And now, albeit that might sound a bit harsh, but it's a very important reason why the nephrotoxic or nephrotoxicity has to be sort of, or should be understood from this perspective. Now, just a little bit more around this. This is slide 8 now. So clinical immunosuppression has actually been plagued, unfortunately, with maintaining a balance between rejection of the transplanted organ and complications of over immunosuppression, including infection and malignancy. And malignancy is a big one, because basically with immunosuppressive therapy, for example, and it can come down to some things as simple as for example, some simple things as self-care. Now this sounds like very primitive, but let's say, for example, if individuals who are transplanted are not very clean, and plus they're taking different medications, for example, then actually the effects of the immune system can actually cause or elicit some sort of responses and issues around a transplanted organ quick as well. And this might not be a direct thing, but malignancy can come out of the fact that self-care and cleanliness around health generally can cause that problem as well. And again, malignancy from the immunosuppression therapy is one of the devastations of immunosuppression therapies that have been implemented sort of retrospectively, because of the sort of apart from the nephrotoxic side effects, there's other side effect profiles that can be with certain pharmacotherapy that can also trigger the malignancy around individuals' health as well. Now, scientists with clinicians must understand or should understand that current immunosuppressive regimens and associated effects can cause problems generally. Now, whilst all transplant patients receive some form of immunosuppressive therapy, some, by the way, and I didn't mention this earlier, but some can be on a single dose, a single form of transplant therapy. Some can be on like a double dose of immunosuppression therapy, and some can be on like a triple dose immunosuppressive therapy. So this basically indicates for example, however many immunosuppressive agents or immunosuppression treatments an individual is on, is also a reflection on basically how well they were cross-matched when they had a transplant as well. So this is important understanding to have, and part of the nephrotoxicity aspect as well. So whilst all transplant patients are on some form of immunosuppressive therapy, the combination and choices increase as new drugs are developed. In the critical and acute settings, newly aged patients will probably more than likely receive induction therapy. And induction therapy is basically where so, for example, let's say the patient's been worked up to have a transplant, had all the serological tests and investigations, and then what happens is that when, say, for example, a couple of weeks, maybe a month, 3 weeks, maybe a month before they actually go under the knife to have their transplant, induction therapy is provided so that the immune system and the physiology can begin to tolerate a foreign an organ that is going to be obviously foreign to the to physiology and immunology. And so by having induction therapy, there's a high probability that the MHC and HLA side of things, that they actually tolerate the foreign body much earlier, and in a better way. Now the goal of induction therapy is to increase long-term patient and allograft survival while preventing or reducing rejection episodes. Several agents are available for induction therapy, and each transplant center designs its own protocol. And this is important because, again, whether someone is, for example, in the UK, whether someone is in Canada, or whether someone is in the US, or whether someone is in a side of Europe or anywhere else, generally speaking, the immunosuppressive or immunosuppression protocol that is implemented is actually a protocol used or implemented according to in some contexts, according to and specific to what that country is about, or what is the main protocol around a particular country. But of course, on a more specific, from a more specific sort of genre, is basically where the guidelines and the frameworks are used, that colleagues in for example in nephrology, or in clinical science or biomedical sciences may have evidence based, and those protocols are used to compare and contrast which is best for the patients who are undergoing a form of transplantation. Now, as understanding of the mechanism of action and additive effects of a drug allows professionals to optimize therapy while decreasing adverse effects. Immunosuppressive therapy offers potential for reducing reducing detrimental patient outcomes and improving allograft survival. And it is well established, or it has been established, that repeated rejection episodes sort of correlate with poor long-term graft survival. And just a quick side note here, listeners, is that allograft, the terminology allograft and the terminology graft, they both mean the same thing, and it relates to where a transplant has been grafted into someone who is a donor, into a recipient who requires a transplant. So I'm not going to move on to slide 9. Not much more to go, and hopefully give an overview in a summary as well. The pharmacokinetics of older immunosuppressive drugs, including one of the main unknown drugs, immunosuppressive or immunosuppression agents from retrospectively was known as cyclosporin or cyclosporin A, and then came along another one called referred to as tacrolimus, and then another one which referred to as mycophenolate mofetil, and then another one a little bit later after that, or more in more recent years, albeit still a little bit. It's now a little bit older, probably over a decade or 15 years old now, which is referred to as sirolimus. Now, these are all complex in their own way, and they do all have different pharmacokinetics, albeit cyclosporin A and tacrolimus have in some contexts have similar pathways where pharmacokinetics is concerned, but not identical. Again, a narrow therapeutic index unique to each patient, as well as variable absorption, distribution, and elimination, are characteristics of these drugs. And now, basically, mentioned, for example, where therapeutic drug monitoring is concerned, there is the area under the curve. Now, in regarding to this, therapeutic drug monitoring plays a fundamental role in helping clinicians, again, to maintain blood and plasma levels. So variation in concentrations outside the narrow therapeutic ranges. And by the way, because of the toxicity, and this is the main thing, because of the toxicity of immunosuppression therapy and what they do, basically they will all have at least one thing in common, and that is that they all have a narrow therapeutic index, because basically when patients have these, basically they will be dosed or they will be prescribed according to whatever the clinician feels necessary. But what will happen is that patients will have to have immunosuppression therapy, not just throughout the whole time that they have a transplant, but also during the time when they have when they take their pharmacotherapy. Basically, they have one dose, for example, in the morning or midday, and then there may be a dose in later on. So in that time, in say, for example, 8 to 10 hours, or 8 to 12 hours, in that sort of gap duration, basically within the blood there has to be enough concentration or trial levels so that the immune system doesn't act up. So basically, in this context, I'm going to say that basically it is up to clinicians to ensure that the therapeutic drug that the trial levels are actually going to be sufficient enough, whereby, for example, and it's kind of a blasé kind of perspective, but this is in literature this has been documented in evidence retrospectively, and that is basically where, for example, if patients, for example, forget to take a dose of their immunosuppression therapy, then basically within the physiology of those individuals, if they had their last dose, like so rather than 8 or 10 hours as the last dose, the dose before that would have been, say, for about for example, would have been over 12 hours. There would be enough of the immunosuppression therapy that the immune system not only tolerates.
Shahid, just to remind you of the time, because
Yes,
if
okay.
you can, sorry about that.
Yeah, sorry. Yeah. Okay. So yeah, sorry about that. I am running a little bit over time. So I'm just going to say that what happens is that the immune system can tolerate the trial levels the trial levels enough so that it doesn't again elicit a response. Now I'm gonna skip move on to the final slide now. So apologies for the length of time here. And this is slide 10 and just a summary. And so during the past decade, several new potent immunosuppression therapy with different modes of action and different side effect profiles have become available, as mentioned. And so all drugs have therapeutics that can have can induce, again, nephrotoxicity, and nephrotoxicity is difficult to distinguish in allograft rejection, and is still a particular problem in the setting of renal transplantation, in more ways than one. Minimizing immunosuppression induced nephrotoxicity improves allograft survival. However, to obtain significant long-term improvement in allograft outcomes, it may be necessary to adopt a new, different, more novel regimens, which are developed through after clinical trials, as mentioned. Now, again, and finally, really, the challenges facing sort of biomedical and clinical scientists and clinicians should actually now be focusing to address the equality aspect around transplantation and nephrotoxicity, so that patients are less probable to have the effects, educational support, and burden of disease post-transplant. And that is the end of my presentation. I apologize for the length of this. There are a few references, and I won't read them out here, but a few acknowledgements, if you don't mind me highlighting. I just want to dedicate this work to dear and departed friends, and these are all people that have unfortunately passed away with chronic kidney disease in recent times, and I'll mention them by name if you don't mind, just quickly. So Ian Purchase, Emma Marquick, Sifal Kirbish, Ratna Das, Maureen Amondi, Everton Barkley, Carl Luton, Margaret Cromley, Christine Gaynor, David Stevens, Phil Starr, Rob McBurney, Rob Argue, Leanna Bruce Kidman, and many others who have lost their lives to chronic kidney disease, or CKD, over the years. Thank you for allowing me to present this topic, and again, I apologize for the length. Thank you.
Thank you so much. That was a great talk. Well, I'm looking forward to seeing it shared. And yeah, thank you everybody for attending. Thank you again for speaking. And I think we're going to wrap up for now. Thank you everyone, and have a nice evening or day, depending on where you are. And yeah, goodbye.
Thank you.